This week's Grand Round. Today we have a special guest. We have Dr. Leonard. She earned her MPH from UT Houston and her BSN from here, actually from University of Texas Health Science Center, and her A&D from University of Albuquerque. Since 2008, Dr. Leonard has been a research nurse, research coordinator, grants manager, and neurosurgery stroke program coordinator over at UTHSCSA School of Medicine. Off campus, she is a science and medicine advisor for the American Heart Association Dallas chapter. And Dr. Leonard's expertise is in primary and secondary stroke prevention and research. Along those lines, we're happy to have her speak today on stroke and the elderly. So thank you so much.
Thank you, Jose. It's good to be here. I do want to make one correction. I'm not a doctor. But thank you very much, Jose. So I'm glad to be here. As Mark knows, and as Jose knows, my career in stroke goes back a long, long way. And thanks. I always like speaking about stroke. Talking about stroke in the elderly is kind of interesting because while strokes still occur and elderly bear the highest burden, we're seeing strokes in younger and younger people, and I'll show you some slides to kind of confirm that with you. Can you see the slides okay, or do you want lights a little bit? Yeah.
Over the screen.
So these are the objectives that I sent, and I hope to, towards the end of the talk, we have some time for questions and just discussion back and forth, because that's always a kind of a useful experience for people.
Chat with you after too. Yeah.
So this is the epidemiology of stroke. Almost 800,000 strokes occur in the United States each year. About 600,000 are generally considered first or new strokes, and a lesser proportion are recurrent strokes. Of course, both of those pathways, whether they're first strokes or second strokes, offer us an opportunity for prevention. Stroke used to be the third leading cause of death in the United States, and the CDC's report that came out about 2 years ago diminished stroke to the fourth leading cause of death in the United States. And so while that looks great on paper, basically what happened is that the CDC combined all respiratory illnesses, chronic and acute, together, and the numbers ended up making respiratory illnesses come in third. So I don't want you to think that we won the battle with stroke, because we certainly have not. These statistics here tell us that we have a lot of work to do. Stroke is the first leading cause of adult disability in the United States. And in particular, when you see what strokes occur across all age groups, but of course the elderly become really affected because of course it's very difficult. They're fragile people, they're old people. It's hard for them sometimes to recuperate. They don't have the resiliency that a younger person has, of course. Over 4 million stroke survivors in the United States, and the cost of stroke is astronomical. The direct and indirect costs are amazing. The direct costs we kind of understand. Those are the hospital costs, the medicine costs, the physician costs, all those costs associated with, say, the acute illness. It's the indirect costs that actually concern me even more. Because what ends up happening, and I see this with my intracerebral hemorrhage patients over at St. Luke's, what ends up happening is that when strokes occur in younger people, then you've lost those people to productivity and contribution. if you will, to society and to community. So in my studies, the youngest person I put on one of my studies recently has actually been 26 years old. The next youngest is 28 years old. So folks, I would argue...
The females or males?
Females. And I would argue with you that stroke's a major public health problem because of that. These are people that don't go back to work and end up having to be subsidized just to help them through the rest of their lives. It crosses all ethnic, racial, and socioeconomic groups. So stroke is not just a disease of poor people, certainly not. It is an equal opportunity disease. So this is a slide, this is from NHANES, which is a large CDC community survey, and this kind of gives you a picture for strokes that occur in different age groups. So over here to the left you see the 20 to 39-year-old age group, and you can see that in the period of 2007 to 2010 they captured a small percentage, and then as we move up the age continuum you see that with age the incidence of stroke rises, which is kind of a no-brainer. So as you can see, once you hit 80, your chances of having a stroke end up going upwards of 14% risk just with age. So that's, just something that it's intuitive, we all know it, but seeing it on a graph, and especially comparing and looking at the trends of younger people having a stroke is really, really interesting. And remember, these 80-year-olds are out of the workforce anyway. These are Medicare recipients. These are people that, are in their retirement. And then you go on these strokes in younger people, and you begin to see what the public health cost to strokes are, and the importance of prevention. This is the annual age-adjusted incidence for first-ever stroke, and there's different years here that are represented. Unfortunately, Black Americans still bear the highest burden of stroke in the United States, and the primary reason for that is uncontrolled high blood pressure or uncontrolled high blood pressure. African Americans bear the highest burden across, with non-Hispanic whites and actually also Hispanic whites. Now, we're beginning to understand a little bit more about Hispanics. Hispanics right now are lumped into the category of white. However, I will tell you that some of the research that I'm involved in, we are specifically targeting this ethnic group of Hispanics to try to understand if their profile of risk is different than whites or blacks. So this is a good thing. As you know, Hispanics as a minority is the fastest growing minority in the United States. So prevention in that population is going to be very important as well. You can see that this is broken up to by ischemic stroke, hemorrhagic stroke, and then subarachnoid hemorrhage. Now, subarachnoid hemorrhage, and I'll show you a pie chart in just a minute, it encompasses the fewest number of strokes. Usually these are caused because of ruptured aneurysms. But intracerebral hemorrhage, the bars in the middle, while it was thought to be a lesser cause of stroke, when you're doing the research and you see these people coming into your hospital all the time, you realize that it's probably more of a public health problem than people thought before. And I think as years go forward, and these years go up to 2005, as NHANES data catches up and the CDC is able to capture that, I think we're going to be seeing more and more intracerebral hemorrhages.
This is the latest data we have right now?
Yes, from NHANES, correct. NHANES is always a little bit behind because they have to get the survey data in, and but this gives us a very nice snapshot. And certainly these trends are not going down. We would suppose that they are going up. So the bar graph should actually be higher because so far prevention modalities are really not working that well.
I think some of the reason with black ischemic stroke being higher is, I understand the hypertension, but I read once that they're called dipping or dippers or non-dippers essentially.
And the only way to know that, of course, is to do a long-term blood pressure monitoring during sleep. Exactly. I don't think we have definitive information on that. Certainly there have been some good studies that have shown that, and it's very, very interesting.
I find it interesting.
But I think there is, for blacks, and this is, I think we can safely say that there's a genetic component here. It's not just that they're necessarily non-compliant, which many are, but with medications, but I do believe that there's a genetic predisposition to that, to hypertension. And I'll tell you why I think that. I do medical mission, and I went to Tanzania, Africa, and in my very brief experience there, I expected, as going to do medical mission in Africa, that I would see people, Africans, with a non-Western diet, for instance. I would have expected to see them without hypertension. A lot of them had hypertension, and a lot of them were being treated for hypertension. So I believe that in the black community there is a genetic predisposition to it.
And also the Caribbean, because I'm from Barbados.
Absolutely.
You have higher rates there also.
Well, the Caribbeans actually came from Africa, so yeah.
So you have, and my second point was that I work at the senior centers on the east side. I have a center that is all, I guess 99% African American. So I've had the students trend in blood pressures over the last 3 semesters. And it's interesting what we're seeing also. In addition to the genetic piece that's there, also the, I guess, the understanding and the ability to, we see the pressures are not excessively high, but they're not normal, and they're on medication.
Right.
So we're seeing that every semester. And
Well, and one of the things, and that's a very, very good discussion, one of the things that concerns me in my practice, what I see, people don't like taking a bunch of medications. Now, many African Americans especially have to be on multi-antihypertensive medicines. I've seen one of my patients on 6. They don't want to do that. So there's a combination of things going on. The doctor may try to put them on the medication, but they don't want to take on the medication. So blood pressures may not be optimally controlled for several different reasons. But I agree with you. In intracerebral hemorrhage, what I see are basically 3 scenarios. People that come in with bleeds that don't know they have high blood pressure. People that come in with bleeds that know they have high blood pressure but are non-compliant on their medication. Then I see people that come in with intracerebral hemorrhages that know they have high blood pressure, are on antihypertensive treatments but are not treated to goal. And goal is tight. It's 120/80. That's a big shift. If you've got hypertension and your curve is shifted to the right, shifting that back to the left, your autoregulatory curve, it takes a lot of work. Patients get frustrated. They go back to the doctor and they get frustrated. Doc, why isn't my blood pressure coming down? And it may be that for whatever reason they have resistant hypertension.
Yeah, there's one lady, she's at the Claude Black Center, and she has 3 meds. And she's always above 140, 150s, 140s.
It's
and
frustrating for them, isn't it?
And she's very frustrated.
It's so frustrating. Then, encouraging lifestyle changes. You got to cut the salt, and salt's, let's face it, it's hard for me to cut salt. But people who, that's a really important part of their diet, it's tough to cut salt. But, so, this is the annual rate for first ever cerebral infarction by age, sex, and race. And here we go again with the age demarcations. To the far left, we see that the age starts at 45 and then works its way up to greater than 85. And again, you see that octogenarians have the highest risk of stroke the older you get. So, and then if you look at, so there's white men, white women, black men, black women, and white men over age 80 die, suffer the most. And I think partly that's because what ends up happening is that black men die before white men. So if you look over here to the right, at about, 20%, I can't see that far, black women have a very, very high incidence of first ever stroke. So it's very interesting to watch this, and as you'll see, women in general have the higher risk for stroke. They live longer than men, and so if you live longer, you have a greater chance of having a stroke, right? Oops, sorry about that. I just had that, I'm sorry. So this is the age-adjusted incidence for stroke or transient ischemic attack in the ARC study. And this data comes from 1987 to 2001, and this is a long longitudinal study, still going on as a matter of fact, where they're tracking this kind of information. And as you can see, in the ages of 65 to 74, for age-adjusted incidence, the risk is actually very, very high. If you look at black men, they're upwards of 16% or more, a little more than 16%. So again, just making the case that age is a factor, but also race is a factor as well, and gender. These are the age-adjusted death rates for stroke by sex and race as ethnicity. We have very little information on Pacific Islanders and Native American. We just don't, those populations, especially Native Americans, are just not studied that well. But again, and over here, over to the right, we're beginning to get information on Hispanics. They did not start collecting information on Hispanics until fairly recently, dividing them out, self-identified Hispanics, until really recently. So we're beginning to get a better snapshot of the Hispanic population in the United States, which of course is a mixed population of Dominican Republic, Central American, Mexican, South American, So it's a very mixed, heterogeneous population.
Also in the Hispanics, I think diabetes would be a biggest cause for stroke rather than hypertension.
Absolutely. Absolutely. It's very interesting. I put a lot of Hispanics on my research studies. It's very interesting because some of the Hispanics with intracerebral hemorrhage, they have a history of high blood pressure, but it's kind of interesting, and I can't wait till this study's completed. There'll be 3,000 patients in this epidemiology study. Some of them don't have diabetes. In fact, a lot of them don't have diabetes. In fact, a lot of them are thin. They're not the obese people that we think of always as obese Hispanics that have diabetes and have bleeds. It's kind of different. It's going to be very interesting to see. But you're absolutely right. Diabetes causes small vessel disease. If you got hypertension, you're in big trouble because if that's not controlled and you have small vessel disease, you're going to have an intraparenchymal hemorrhage. Good point. So this is kind of very interesting, and it kind of shows you, this is from the Framingham study, one of the most well-known epidemiology studies in the world. Estimated 10-year stroke risk in adults 55 years of age according to various risk factors. And you can see on the left there, blood pressure has been thrown into the mix, diabetes, cigarette smoking, atrial fibrillation, which is a very important risk factor for older women especially, older people in general, but older women in particular, and then prior cardiovascular disease. And you see, as you move along from A, B, C, D, E, F, when you get to F, the more of those risk factors you have, naturally the risk of stroke goes up. So if you look at the bars on F, on the far right, you see that your risk, women's risk approaches 30% with all those risk factors. So what do we see here in San Antonio? We see all of those risk factors, don't we? So, we don't have a healthy population here, unfortunately, and this is what we see.
So that's the diastolic, systolic and diastolic.
Yeah, what they did is those are ranges for systolic. Okay. Yes, correct. Okay. Systolic is one of the most potent risk factors when you're talking about hypertension for ischemic stroke. And so what they did is they put a range in there and kind of use that range across the board. And if you look at that, that's a fairly low range compared to what you and I might
Well, that's what we're seeing. That's what I'm seeing at 130s, 140 for my clients on the east side.
And you know that blood pressure, the JNC7 guidelines came out and said that, there's this thing called pre-hypertension, right? And pre-hypertension is actually fairly what we consider low systolic. It's greater than, I believe it's 129, it's like 130. Yeah. So that's kind of scary, but we're beginning to drill down, we're beginning to catch people at an earlier age and to see that, hey, hypertension may be starting at that level, pre-hypertension, rather
so
than...
the diastolic is not so important?
It is important, but not, more important for heart disease versus stroke. Systolic hypertension is really, really the primary driver. Some of the blood pressures that I see over at St. Luke's in my hemorrhagic stroke patients are approaching 300 systolic. So very, very high. And the diastolic may follow that, but it's really the systolic that's driving the risk for stroke.
And that's because of the pressure, the increased pressure, that's also put on the vessels, the small vessels.
Absolutely.
Okay.
Yeah,
So
absolutely. Yeah.
it's not related to the vessels themselves or the pressure.
The brain can't tolerate high levels of high blood pressure forever.
Mm.
Its compensatory measures will give out and play out over time. So we call it's the autoregulatory curve, and most of us who live in 120 or less, our autoregulatory curve is shifted to the left, which is normal. People with hypertension, over time, their autoregulatory curve shifts to the right. So there's this compensatory mechanism that's occurring as the shift is occurring and the systolic blood pressure, for instance, is going up. Mm. Over time, the brain can't take that. Now, which people that affects, we're seeing younger and younger people where it affects. I think we used to think that that happened over time and over years, many years. But we're actually seeing that happen in younger and younger people. So there's got to be something else going on there. So just when I teach my patients and families about the autoregulatory curve, because what they want to see is blood pressure coming down immediately, and they get freaked out if it doesn't come down immediately. And what I try to tell them was, hey, getting it reshifted over to the left may take a long time, just like it took it a long time to shift to the right. So the autoregulatory curve is very, very important, and what it does is it puts a lot of stress on those little fragile blood vessels, and with the person with diabetes that
So is the primary cause the constriction of the lumen of the vessels increasing the pressure?
Yeah, because what happens is that the intimal lining of the blood pressure just gives out, of the blood vessel just gives out and becomes diseased. High blood pressure actually causes disease of the blood vessels themselves. They lose elasticity, so they're not as compliant, and they just give out.
So does a person become hypertensive because their arteries, their circulatory system is getting smaller in its lumen size?
Probably partially.
Atherosclerosis?
Probably partially, yeah.
Stress, does that
Probably
constrict?
a lot of different mechanisms that might cause, when you may develop high blood pressure differently than I do,
Fat accumulate?
Pardon me?
Fat accumulate?
Absolutely, yeah. Atherosclerosis, and we see atherosclerosis more in older people. But in younger people, what is the mechanism? It's probably not atherosclerosis, right?
Stress.
Shear stress. Yeah, exactly, just that.
Shear stress.
Yeah, over time, the body's not going to tolerate it. We're not meant to have high pressure.
Have you seen studies or any kind of literature related to that?
No,
Okay.
just
Or your
from
patients?
like Harrison's shear stress.
Yeah.
It's just stress. Whether it
Against the wall of the blood vessel.
whether it increases the media portion of the vessel is a different
Mhm.
story. But the shear stress, it can't handle it.
Right.
Now, when you say shear stress, what do
High pressure.
you mean?
It's like
Actual
okay.
shearing stress.
Well, think
Pushing.
about think of a hose, and you plug it up on the other end. And what's going to happen? Eventually, that hose is going to give out, right? Because the pressure is too high.
Yeah.
Right. And so, but there are other mechanisms. There are other things that can cause that too. Kidney disease can cause high blood pressure.
Diabetes.
Heart disease, diabetes.
Sugar alone can cause stress.
But isolated hypertension goes back to what he's talking about, and that is the primary cause is probably shear stresses, maybe the only
Smoking
cause.
and things like that.
Adds to it too, absolutely.
But what about children now showing an increase in NAFLD and all that stuff?
That's just obesity.
That's obesity, yeah.
Childhood.
That's what I'm saying.
Plain
That may
parents
be-
not taking care of the kids.
That may be the other reason for the increase now in children.
Right, exactly. Yeah, and that's our population for the future, people,
Yeah.
sadly. So this is the proportion of patients that were dead within 5 years after first stroke. And white women, white women, of course, they actually live longer than black women, but if you look at black women over here, you'll see that the percent is actually pretty high. So stroke, while you may survive the acute phase of it, you know, your chances of death out to 5 years are really pretty high due to several things, and we'll talk about the complications of stroke in a minute. So, backing up a little bit, maybe I should have done this first, but I kind of wanted just to review the incidence of stroke with you. I've had this pie chart forever, and actually have another algorithm that I use. I can't turn it away because this belonged to one of my mentors, and I always think about him whenever I put the slide up. But anyway, this just shows you the types of stroke. There are 2 types of stroke, and we've talked about primarily ischemic stroke, and that's the largest number of strokes that occur in the United States. Usually about 85% of all strokes are ischemic in nature, and ischemia simply means that there's a blocked blood vessel to the brain, causing lack of blood and oxygen on the other side of the blockage, and cells die. In fact, brain cells die within 3 to 4 minutes after having blood and oxygen shut off to them. A smaller proportion, 15%, are due to hemorrhage. And the primary one that I work with is intracerebral hemorrhage. And of those 15%, 67% of hemorrhagic strokes are intracerebral hemorrhage. This is the most deadly type of stroke. And especially if the people I see are people with intracerebral hemorrhages with also interventricular component as well. So of the 85% of strokes, there are several. Stroke is a syndrome of many different causes, not just one cause. There are atherosclerotic large vessel disease strokes, that is strokes of the occlusions of the carotid artery because of buildup of atherosclerosis, fatty plaques, that type of thing. Secondary to maybe smoking, diabetes, and high blood pressure. Then about 20% are due to cardiac emboli. That is heart disease. The most common source of cardiac emboli for stroke is atrial fibrillation, non-valvular atrial fibrillation. Lacunar strokes are small vessel disease, about 25%. That's what we see mainly here in San Antonio, in our Hispanic population. Because of the diabetes and the addition of high blood pressure, they get small vessel disease, and I'll show you an MRI in just a minute. And then, unfortunately, 5% are due to other unusual causes, but the really unfortunate part is the unknown. About 30% are cryptogenic. We don't understand what the cause of stroke was in some people. That's very disheartening to family and patient when they don't know what risk factors they should modify. And some of these people may not have risk factors at all. So that's that's tough. This is the pathogenesis of ischemic stroke. So basically, well, let me move up here real quick and just kind of show you this. Remember I told you that within 3 to 4 minutes, brain cells die. So you always will have a core area of infarction or dead brain tissue, and you're going to develop a neurological deficit because of that. This pink area around the core area, is what we call the ischemic penumbra. And basically, our acute interventions such as with TPA, tissue plasminogen activator, which is the only approved, FDA-approved drug to give an ischemic stroke. What we hope to do is to reperfuse, lyse the clot, reperfuse, and at least get circulation back out to the penumbra where we may still have viable brain cells to save. Now, stroke's tricky. Remember I told you 3 to 4 minutes and brain cells die? Well, EMS is never going to get to somebody within 3 to 4 minutes, right? And patients are never going to get to the hospital within 3 to 4 minutes after the stroke starts. So, again, ischemic penumbra is very, very important. But the longer you wait to try to get therapy, such as tissue plasminogen activator, to the patient, the greater the chance we have of all the tissue going to infarction and dying completely. So this is
the pointer. I think there's a pointer, the smaller one, right? Right, Mark?
I don't think it works. I think that Mark told me that it was DOA.
Oh, okay.
So anyway, that's just a quick synopsis of the pathogenesis of stroke. In the stroke world, we try to classify stroke by the temporal profile, like how long have the symptoms been there, the vascular anatomy of the vascular territory, and also what the mechanism is. You'll see that the mechanism is the same as what I had on this slide, the pie chart before. Transient ischemic attacks, I believe, are one of the most important things. People call them mini strokes. Sometimes you hear minor stroke. If somebody has a TIA, the unfortunate part is that many people with TIA ignore it. And because the symptoms of stroke go away so quickly, they think that nothing's wrong. Well, this is the perfect opportunity for somebody to intervene and do a TIA workup, put them on an antiplatelet therapy to prevent that patient from going on to have a stroke. The definition of stroke used to be a focal non-convulsive neurologic deficit that lasts less than 24 hours. That definition is changing and evolving. Now that we have wonderful neuroimaging these days, like MRI, we can begin to see whether there's tissue that's alive or dead. We can look at diffusion-weighted imaging, FLAIR, and all those fancy multimodality MRIs and decide if the patient's actually had a stroke or not. So you can call it a stroke by tissue. It's called a tissue definition. So that's really exciting. We're moving on forward here. So about 15% of all strokes are heralded by a TIA. Many people just miss it. About a half of the patients who have a TIA fail to report it to their physician, nurse practitioner, PA, whoever. And the 90-day risk of stroke after TIA has been cited in many studies with a range of between 3 and 17%. So I'd hate to be on that 17% end of the range. Stroke after TIA is highest in the first 30 days after stroke. So more and more now in the stroke community with stroke experts, we are really, really pushing. I personally believe, this is my personal opinion, that patients with TIA should be admitted to the hospital. If you admit a patient to the hospital with a TIA, and that patient, if you look at the odds of them having a stroke, 5% have a stroke in the next 2 days. That patient's in-house in a hospital, and they have a stroke in hospital, you potentially could give them tissue plasminogen activator pretty immediately, okay? So that's my, but will the healthcare system bear that burden of admitting a TIA? Will they pay for the workup? You know. Yeah, and actually, great point, because that has actually been brought forward. Bring them in, put them in observation, do a quick, at least a carotid Doppler, look for something in the carotid arteries, do an EKG, look for A-Fib, you know, these kind of things. But absolutely, I think we're going to see, because we're realizing how important TIAs are, I think we're going to see more and more doctors just going ahead and admitting and trying to get a workup, you know. Yeah, go ahead.
In regards to like the medicine point of view, do you recommend the ABCD criteria for
That's
it?
a great
because
question.
it's really not used for an admission criteria, but it addresses the problem.
It does. So ABC,
Risk of stroke.
it's a risk of stroke with TIA. Yeah. So the more ABCDs that you have, the greater your risk of having a stroke if you're a TIA. Now, Claiborne Johnston, and I've forgotten the guy from England who actually developed ABCD and then ABCD squared, right, truly believe in it. And I do think that there probably is a place in that. I really do. I think there probably is. Will it be widely used? Probably not. What doctors can, I mean, a lot of academic physicians may do it,
yeah,
but other docs may not do that. I think I got to move forward, guys. These are the cardiac abnormalities associated with ischemic stroke. Just wanted to put those up for you to see that, again, a stroke is not just a stroke, and these are the different ways that patients can have strokes via a cardioembolic source. This is just a couple of pictures showing you what an atherothrombotic stroke looks like. The picture of the angiogram on the left shows you a very tight stenosis of the internal carotid artery with an ulcerated plaque. I'm sorry, yeah, with an ulcerated plaque and clot, actually. And then on the right, you see that this patient has undergone a carotid endarterectomy. Small vessel disease, which we see very, very commonly here in San Antonio in all age groups, but we really do see this in younger Hispanic people. And again, the syndromes are listed on the left. The age, usually less than 60, although we can see it in older people, you know. The average age in the SPS3 study that just concluded, which specifically looked at secondary prevention using antiplatelet and blood pressure control in these patients, their average age was 63 in that study. This is an MRI basically showing you on the right, you'll see, well actually on the right and the left, the MRIs, you'll see these small white dots around the ventricles of the brain, and those are small lacunar infarctions. So this patient, so lacunar infarctions are kind of dangerous because when you have a bunch of them, it doesn't make you any smarter. You begin to have cognitive decline because of it. As well as also having deficits, neurologic deficits that may impair your activities of daily living. So what are the risk factors of stroke? We've talked about a lot of them. Age, of course, really one of the most potent risk factors. Race, ethnicity, hypertension, diabetes, heart disease, especially atrial fibrillation, hypercholesterolemia, cigarette smoking, physical inactivity, alcohol abuse, illicit drug use, and obesity. Of course, we've already shown that stroke increases with age. But as we see patients, elderly patients with risk factors, that's a wonderful opportunity for us to intervene and try to modify those risk factors the best we can. Let's face it, if I'm an 80-year-old, the last thing that I want to have towards the end of my life is a stroke and to potentially be ending up in a nursing home. It's higher in risk, the risk is higher in older women, particularly black women, and for women in general, since women outlive men and they develop atrial fibrillation because they get older, atrial fibrillation is a very, very important risk factor. Race, ethnicity, we've already discussed that blacks or African Americans bear the highest risk overall. A predominant risk factor, of course, is hypertension, diabetes, smoking, and obesity. Hypertension, other than age, again, hypertension is the most potent risk factor for stroke. It's also the most preventable and treatable risk factor to prevent stroke. 80% of all strokes could be prevented, but unfortunately, a combination of patient error in judgment and not being compliant on medications or not whatever, physician error and maybe not bringing blood pressures down to target goal, as we discussed before, family errors weighing in saying, oh, you don't need all those medications, take this herbal therapy, this will probably help you. Unfortunately, we can't prevent as many strokes as we would like. Hypertension raises the risk more than tenfold. It's estimated that over 72 million people in the United States have hypertension, and just think of those people that are going to go on to have strokes, and they will. Randomized controlled clinical trials show that reductions in blood pressures can reduce the risk of stroke anywhere from 30 to 40%. So those are pretty impressive numbers. Again, some patients do not treat hypertension to goal in the elderly, thinking they need more cerebral perfusion pressure. I think you'll agree with me. Some old docs actually had that, thought, oh my God, we got to keep the brains perfused. Well, do you keep their brains perfused, or you risk having a stroke? So I still see that in my practice, believe it or not. And it just is amazing to me that, but it still happens.
I don't get it though. The brain is perfused, so therefore they're not going to get stroke.
Well, they think the idea is that if you're an old person, you're not getting as much blood to the brain. And
it's okay.
And then if you lower the blood pressure, you're getting even less blood pressure and blood to the brain. Yeah.
Okay.
So you're not getting the good. Okay.
All right.
Diabetes, it's estimated that about 8% of the adult population has diabetes. Now that's known diabetes, right? And then think of the ones that are undiagnosed. Yeah. It's a clear risk factor for first stroke. It also causes small vessel disease, as we discussed before. And the elderly are at risk for ischemic stroke and intracerebral hemorrhage because of diabetes. We've reviewed that before. Obesity, I love this section. The American Heart Association is now including obesity as a major risk factor for stroke, and I think that it's clear to see that going forward, we have to say, hey, it's a risk factor for stroke. We can't ignore it anymore. I love this one. If you'll see the little guy, the little skinny guy over there, the little smoking guy, is being overtaken by the big guy, the obese guy. Step aside, Stream Bean, there's a new killer in town.
Oh, wow.
And how true is that? Just when we think we're beginning to win the war on getting people to stop smoking, another major risk factor steps into the picture. This is just giving you a definition, classic definition of obesity, and obesity, of course, runs the gamut. We see it in young children, unfortunately, in our country, but we also see it in the elderly. So, major problem. This just gives you an idea of the risk of obesity and heart disease, but if you look below death-wise, there's a 5 times higher risk of death if you have obesity and you end up having a stroke. So, there is a connection there. Atrial fibrillation, this is the very first study that I ever did, actually here at the VA, right down on the 3rd floor here, was called Stroke Prevention and Atrial Fibrillation. It was the brainchild of Bob Hart and David Sherman, who were in neurology back in 1987 when I started. They got their first NIH grant, and it was the SPAF study. And it was a historical study showing basically that atrial fibrillation, stroke could be prevented in atrial fibrillation if people took Coumadin. So a landmark trial, very proud of that. But about 15 to 20% of all strokes are due to atrial fibrillation. It's a cardioembolic source. Over 2 million people, Americans, have atrial fibrillation. And as I said before, it's the most common heart dysrhythmia in patients over the age of 65. So the longer you live, and again, women live longer, the greater your chance of developing atrial fibrillation and then a risk for stroke. Comorbidities associated with A-Fib are age, again, we discussed that, heart failure, hypertension, diabetes, and prior thromboembolism.
Does hydration affect atrial fibrillation at all?
Not that I'm aware of, but our doctor colleague might know that. Not that I'm aware of, unless you could argue that it causes a hypercoagulable state of some kind, but I don't think so. No studies that I've seen have related to that.
And with Coumadin and aspirin, does that reduce?
It does, and I'm going to talk about that in just a minute. As a matter of fact, prevention of stroke and atrial fibrillation. So the standard of care drug is still warfarin. Nothing's really beat warfarin. As far as safety, efficacy, for sure. Safety-wise, there are new drugs on the market. The new direct thrombin inhibitors, the factor 10A inhibitors are on the market now. These are drugs that inhibit coagulation, but don't require regular monitoring like warfarin does. They have equal to or maybe a slightly higher hemorrhage rate. Depending on how well Coumadin is managed. Their INRs, if they stay in range, they do really pretty darn well. And so it'll be interesting to see going forward. Doctors are not jumping on the bandwagon to switch their patients over yet. Their doctors now are just now becoming comfortable with warfarin, after all these years. But it's true, they are. And so then the direct thrombin inhibitors come on board, and there's no antidote to these. There's no reversal like there is with warfarin. So there's a slow uptake to switch patients over to these new drugs. The other problem is these drugs are very expensive. Warfarin is still pretty cheap. It's generic now, and really what you're paying for a small amount for the drug, you're paying for the INR testing, but it's still less than for these other drugs. So, and then aspirin. Aspirin can be given to low-risk people. I think we have to be careful not to assume not to anticoagulate an elderly person. Older people can be safely anticoagulated if you have a good anticoagulation clinic and a good healthcare team watching it. I'll just give you a quick example of the SPAF study. The nurses in the SPAF study, such as myself, that were coordinating the study, were the caregivers and the people that adjusted and managed Coumadin based on the algorithm. We had a very low hemorrhage rate in the SPAF study. So that's good because the patients didn't have a hemorrhage, but it's bad for a study because there were no events. But the long and the short of it is with people that are trained well and are interested in doing that, you don't just have to have a physician or an advanced nurse practitioner in a clinic doing it. If you have stated protocols and good algorithms under physician supervision and clinic supervision, patients can be managed very, very well. Low risk means no risk factors, by the way. No hypertension, no diabetes, no heart disease, no nothing. Yeah.
81 milligrams aspirin or the 325?
325.
325,
Yeah,
okay.
325 is what the SPAF study found out. Other studies done in Europe that use lower doses of aspirin, I think are suspect because we're varying doses in those trials. I'd go with 325 enterically-coated aspirin. Okay. Effects of stroke in the elderly. The morbidity and mortality is higher in the elderly. That makes sense. It's common sense. Elderly are more fragile. They're not as resilient. They don't bounce back. They don't have the energy reserves that younger people do. Stroke recovery is difficult. There is a greater chance for complications in the elderly, and unfortunately they succumb to those complications, and we'll talk about that in a minute. So what are the complications after stroke? Deep DVT, or deep venous thrombosis from immobility, pneumonia, very, very common, in fact one of the most common complications after an acute stroke. And going forward, even after the patient survives the stroke, if they're not as mobile as they used to be, they can still get pneumonia, and elderly are susceptible to pneumonia anyway, right? The complications of immobility, like contractures or decubitus, bed sores, things like that. Stiffness, they can't move, they can't even move one side of their hemiparetic. Falls, of course, are a major danger to the elderly. Depression, I put that in there because depression, I believe, is a major complication. If you don't treat depression, and anywhere from 35 to 50% of patients that have a stroke are depressed, I really encourage when I teach physicians and nurses, find out if your patient is depressed and get them treated. Look for it. You know, don't turn a blind eye, look for it. Hospital readmissions, of course, hypertension, uncontrolled hypertension, again, is, I would consider a complication after stroke. We don't have the best evidence to tell us how to treat, how quickly to lower blood pressure. The data is just not as strong as we want it to be, but we also run the risk of people assuming that if a patient has a stroke, we got to keep their blood pressure kind of high to keep their brains perfused. Wrong. And then, of course, recurrent stroke. This is the impact on stroke survivors. Again, this is from the Framingham study, and these are patients over the age of 65. As you can see, the numbers are, it's very sad. Hemiparesis is the biggest neurologic deficit, 50%. Unable to walk, 30%. Independent and ADLs, 26%. Toileting, grooming, bathing, feeding, any of that. People that have aphasia, about 19%. This is really, really sad because if you lose your language for the rest of your life, ugh. Clinically depressed, I have the lower end of the scale here at 35%. There's a study being presented at the International Stroke Meeting this year in just a couple of weeks that will talk about suicidal ideation in depressed patients, and the range that they give for that is 35 to 50%. And then institutionalized in a nursing home, 26%. Okay, guys, that's it. Any questions? You guys have asked some great questions already. But I'm sorry, I kind of ran through that because I guess do I have enough time? I have enough time.
You have 3-4 minutes if you want.
Oh, good. Great.
Excellent.
So what do you do?
I wanted to get this here.
Oh,
I wanted to get the students so I'm teaching and I'm on the east side of the American community.
Yeah, I met you before in the...
Yes.
Yes.
Thanks, Chico.
I did.
We're doing a Speakers Bureau series for the seniors, and I wanted to really stress this as one of the very important topics that we want to cover with the seniors. Because
If I can, I'm happy to do that, happy to help out, yeah.
I have to get it correct.
No, I mean, I do what you tell me, what you said there, but there's one thing that I'd like to bring up in regards that I don't think is really thought of much.
Yeah.
But stroke in the elderly, and yeah, they fulfill the criteria to get Coumadin a lot of times, because one of the criteria is age. So, and that age is elderly.
Yeah, it is.
We can safely say.
Yeah.
But angiodysplasia in the brain.
Angiopathy, cerebral angiopathy.
Cerebral angiopathy, exactly. So as patients
You're worried
age,
about a risk of bleeding.
yes, and given Coumadin in those patients,
You're afraid will enhance it.
yeah. And even though I read some things on it, there's no really good study.
But how do we know that the patient has cerebral angiopathy? We don't.
We don't.
Yeah. So we
But I
have to
find
take our
it
chances.
interesting.
Yeah.
It's like a new
Yeah.
field that
Yep.
I'd like to hear more about.
Yeah.
Really.
Yeah, and I wish I had all the answers, but I guess what my neurologist friends might say,
Yeah.
they would probably say, you're not going to know that they have cerebral angiopathy necessarily, right, unless you did a biopsy or something like that. Or if the patient comes in with a bleed, secondary to cerebral angiopathy.
And
But I
that's
think
true.
you have to kind of do due diligence in the absence of information. So you know the patient has A-Fib, and you know they're at risk for stroke. What do? Say, well, they might have cerebral angiopathy.
True.
You know,
But I've never
I
diagnosed
don't know
it.
what the
though.
answer
But you
is.
know what's another thing that I thought of too is SSRIs.
Yeah.
So you know, if a patient does have cerebral angiopathy, the SSRIs increase the risk of bleeding, also GI bleeds. And there's a
And
connection
I
there.
don't know what the true incidence of cerebral angiopathy is. I think it's pretty low, actually.
Yeah.
It's pretty low. I can tell you that in our research in intracerebral hemorrhage, I've got over 100 patients just locally here in San Antonio. We've had very few with angiopathy.
Yeah. Okay.
Very few.
So is that a deteriorated cerebral blood system?
Yeah, it's actually a genetic
Oh,
predisposition. Yeah.
and what's the SSRI?
It's a antidepressant, like Prozac and Zoloft, the stuff that we give like candy.
I know, and here I'm telling you, give it more to stroke patients.
I just, you know, I essentially made that connection, but it's in the literature. It's not really there.
Yeah,
The research
exactly.
study then.
Well, and that's the thing, you're right, that's the problem. So then, if that's the case, and they're not a good candidate candidate, maybe they're a candidate for one of the drugs. I don't know if these drugs are even on the VA formulary now. Is Predapsol on there?
The Bigatran is
So
Pradaxa,
Pradaxa
but
is.
you have to, it's strict criteria.
Yeah.
And if they have any,
Because they're expensive.
if they have any renal dysfunction, they're not gonna let you do the lower dose. It's not approved through VA, like
Wow.
Massachusetts. It's-
Exactly. What is it, a GFR of less than 30 or
Less
something like
than,
that?
Yeah.
Something like that.
And the factor 10A that you mentioned there, that's Xarelto,
Xarelto,
They have
yeah.
the Rivaroxaban.
Rivaroxaban.
But it's restricted here only to like after for,
DVT.
no, only for like, if they've had a hip or a hip replacement or something.
Oh,
I
Yeah,
have one patient
Yeah.
that's on that.
yeah, prevention of DVT.
They don't
yeah.
have any, they don't have it approved here.
And they're commercial states, you know how they do the quick,
Yeah.
yeah, they said, however, if you can be, Coumadin is preferred.
Well, and it is, I hate
Right,
to
have
say,
you ever heard that? I
the
don't know
new
where it is.
guidelines that'll be coming out from the American Heart Association, the
Thank you so
updates.
much.
You are so welcome.
Great to meet
Yeah, that was a
Thank
great
you, good to meet
answer.
you.
Thank
Well,
you
I'm
very
glad you
much.
enjoyed it, I'm glad you enjoyed it. So let's look up
Very well.
the rate of cerebral angiopathy.
Yeah.
Oh, thank you, sir.
Well,
Yes, thank you, appreciate it. Multiple things.
Opportunities.
You know what I'm gonna do, I'm gonna send you that email.